for joining us for Unite for Sight's webinar about perspectives on health for vulnerable populations. We are thrilled to have all of you here with us today. My name is Jennifer Staple-Clark, and I'm founder and chief executive officer of Unite for Sight. I will start this webinar by briefly introducing you to Unite for Sight, review the webinar logistics, and then we will hear from our 4 expert panelists. Unite for Sight is a global health nonprofit organization that promotes high-quality care for all. And we offer extensive global health and social entrepreneurship education programs. Our Global Health University program offers a free webinar series, including today's webinar, and we also offer 20 online certificate programs for students and professionals. Many students receive academic credit for completion of these certificates, and professionals often pursue the certificates for professional development purposes. And the certificate topics range from a certificate in global health to a certificate in global health research and a certificate in cultural competency, as well as more than 17 other certificate programs as well. And we will have additional upcoming webinars starting in fall of 2016. We'll be taking a short hiatus over the summer months, but then be back again in September. And we encourage you also to register for free upcoming webinars and also see all of our past recorded webinars at uniteforsight.org/webinars. Additional educational opportunities for students and professionals includes participation in Unite for Sight's annual Global Health and Social Entrepreneurship events, which focus on responsible global engagement. We had our recent 13th annual Global Health and Innovation Conference a little over a week ago, and we are now planning our 14th annual Global Health and Innovation Conference, which is the world's largest global health and social entrepreneurship conference. And it will be held on April 22nd and 23rd, 2017 at Yale University, so definitely save the date. And the conference includes 300 speakers and 2,000 participants for a weekend exchange of ideas across all disciplines of health development and social entrepreneurship. And all of the details will be forthcoming at our website, uniteforsight.org/conference. We also have healthcare delivery programs that provide care to patients living in extreme poverty. We partner with phenomenal local eye clinics in Ghana, Honduras, and India to provide quality care to patients who are otherwise unable to access or afford care. And these programs are locally led and managed by local medical professionals. And our collaboration with those local doctors has provided eye care to more than 2 million people by local doctors during the past decade, including more than 95,000 sight-restoring surgeries by the local ophthalmologist. Unite for Sight is the world's only organization that is a healthcare delivery organization that also offers immersive global health education and social entrepreneurship opportunities for students and professionals. And participants support and learn from the local doctors in Ghana, Honduras, and India as those doctors provide care to patients living in poverty in villages, slums, and refugee camps. And the participants then learn from those local medical professionals about patient barriers to care and about effective strategies to reach the hardest to reach patients who otherwise can't access or afford care. And the local doctors are incredible social entrepreneurs who design effective and innovative strategies to eliminate patient barriers to care. Now that I've described about Unite for Sight, I will describe the basic logistics of this webinar, and we are so delighted to have all of you here with us today. We have 4 amazing panelists, and they have a wealth of expertise to share with you during this next hour. Each of our panelists will start by introducing themselves for about 2 minutes, sharing about themselves, their current role, and their key guidance and advice related to providing healthcare services for patients. And then we'll dedicate the remaining time to your questions and answers. We received many stellar questions already from you, our audience, by Tuesday's question submission deadline, and we selected the most common and most thoughtful questions to ask our panelists today. We also invite you to submit additional questions in the text box on the left of your webinar screen, and then we'll select those questions to ask panelists today as well. And we encourage you as well to tweet about the webinar, including your key lessons learned by using the hashtag GHUwebinar. And you can see that hashtag in the webinar visuals on your screen. So now we will proceed with having our panelists introduce themselves. We'll go in alphabetical order. And I'm delighted to introduce you to our first panelist, Pam Bolton. Pam, please begin by introducing yourself, your background and current role, and your key lesson learned regarding providing health for vulnerable populations.
Jennifer, thank you so much. I am a maternal and child health specialist with many years working in the field, but kind of a hybrid in the sense that partway through my career I became more interested in what business and private sector could do to improve health and quality of life. So I got a business degree. And now, and then I imagined that I would work in a corporation, maybe in social investment or some area like that. But of course, it turned out that I'm still working in the not-for-profit area, but I'm always thinking about private sector approaches, ways in which companies, small and big, can actually work in ways that produce improvements in health for people living in poor settings. So I currently work for an Irish headquartered nonprofit called Concern Worldwide that is active in 29 countries and helped 7.5 million people last year, and works across a variety of areas of humanitarian, which is sort of disasters and emergencies, responding and preparing, and development. And my particular role is leading a program called Innovations for Maternal, Newborn, and Child Health, which does exactly what it sounds like it does, looks for new ways to overcome challenges to health access for women, babies, and young children. Oh, and my advice, yes. So as somebody who's been always working very much in the health sector, I think I used to be really focused on service delivery and facility-based services that were, that are provided by health professionals. And as I've gone along, I've really seen more and more and become more convinced about the huge importance, really, of community-level health interventions, and also of building trust within a community about the formal health system and the services that are available to them. So, for example, I've always been very committed to getting women into health facilities, have their babies, have skilled attendants, and access to essential obstetric care. And I've realized over time that that's easier said than done. And you really need to work a lot with women in communities and understand why they would prefer traditional providers. So, and I've also seen that if you don't provide the quality of care, you actually won't save as many lives as you want of women and newborns, and you might not even save any lives if the quality is really poor. So that just makes me more committed to improving quality of facility-based care, but also finding ways to make sure that health providers can talk with women and families in the communities that they serve.
Excellent. Thank you so much, Pam. And Leith Greenslade, can you please introduce yourself as well and share your key guidance and advice?
Sure. Hi, everyone. So this is Leith Greenslade. I began my career in the late 80s working in government in Australia for the Minister for Health, who was also the Deputy Prime Minister, and then got some graduate degrees, first at the Harvard Kennedy School in Public Policy, and then my MBA at the Chinese University of Hong Kong. And then returned to America when Gavi, the Global Vaccine Alliance, was being established by Bill and Melinda Gates and many other partners to work on the US arm of Gavi. So I was very immersed in vaccines for several years, and then left to join a group called the NDG Health Alliance, led by Ray Chambers, which was a group of leaders who really built public-private partnerships in support of the Health Millennium Development Goals. And more recently, I have started my own venture, finally. I've left to start my own organization called JustActions, which is active on 10 different issue areas, mainly related to women's empowerment and development. My lessons, I've actually put these on Twitter on the hashtag GHU webinar. So you can go and check them out if you're following this conversation on that hashtag. But these are somewhat provocative, and maybe we can get into some of them on the call. But number one, these are hard lessons learned from a long time working in development. Number one, technical expertise is overrated. Number two, it matters more who you work with than who you work for. Number three, and I think this is my most important one, real development is about increasing local control. Number four, honest dialogue is only possible between equals. And number five, beware prevailing development orthodoxies. And maybe we'll talk about some of those on the call today. Thanks, Jennifer.
Terrific. Thank you so much, Leith. And Lynn Michalopoulos, please introduce yourself as well and share your key advice and guidance.
Great. Thank you. Can you hear me okay?
Yes, loud and clear.
Okay, great. Thank you. Thank you so much for having me. I'm an assistant professor in the School of Social Work at Columbia University, and also the founder of the Global Health and Mental Health Unit of the Social Intervention Group of the School of Social Work. My current research focus is threefold, and it's actually heavily informed by my years of clinical practice experience working with women of color who've experienced trauma, specifically sexual violence. So the first area is examining how trauma outcomes vary across cultural contexts, especially in non-Western low-middle-income countries. So under that, I've worked with the Victims of Torture Fund and Johns Hopkins University as the lead developer of a global trauma scale, or an assessment tool which is now being validated in Uganda, Thailand, the Ukraine, and South Africa. And my second area is examining the relationship between trauma, mental health, substance use, and HIV risk behavior, specifically among labor migrants from low and middle income countries who are often at increased risk for trauma and HIV. And most of my work in this area has been with labor migrants from Zambia, for example, fish traders, female fish traders, and truck drivers. And the third area is looking at the adaptation of trauma-informed evidence-based HIV interventions among vulnerable populations from non-Western low-middle-income countries. And to echo what the previous panelists have said in terms of the advice regarding the health needs or solutions for vulnerable populations, I would actually give the same answer for both, and that it's really important and critical to assess the needs from the community perspective, and similarly to garner the solutions from the community, so that the solutions will be contextually and culturally relevant and then subsequently sustainable. And the other piece of advice is that mental health really matters. I think especially with vulnerable populations, we often forget about mental health and emotional suffering. And this, it makes sense in terms of if the basic needs are not met. However, suffering is suffering, and I found in my work that if you are able to address emotional suffering and the mental health needs of vulnerable populations, that this can significantly improve the well-being and functioning of individuals, communities, and society.
Terrific. Thank you so much, Lynn. And our final panelist, Paul Spiegel, if you can also please introduce yourself and share your lessons learned.
Sure. Thank you very much. Greetings, everyone. My name is Paul Spiegel, and I'm currently Deputy Director of what's called the Division of Program Support and Management at the United Nations High Commissioner for Refugees. The role really involves managing four different sections. One is public health, which includes nutrition and food security and water and sanitation, as well as health and reproductive health. The other is looking more at energy and livelihoods. The next one is shelter and settlement, and the last one is cash-based interventions. I'm a Canadian physician epidemiologist who worked for many years at Centers for Disease Control and Johns Hopkins, as well as Doctors Without Borders in the field, Doctors Without Borders and Doctors of the World. I would say what we've been learning, particularly at least some of the advice in looking at the Syria situation and the refugees, the overwhelming amount of refugees in Jordan and Lebanon, Turkey and Egypt, Syrian refugees, and now moving into Europe. I would agree with what the other colleagues have said, that we have to try to figure out ways to reduce dependency, and a lot of the immediate aid work that we do may try to help people in the very short term, but aren't taking into account the long-term issues of sustainability, of using the people's skills themselves as opposed to bringing in what we think they need. And a lot of humanitarian aid hasn't taken into account the development perspective, so often leads to dependency. And so some of the areas that we're looking at more specifically are cash-based interventions, which is really changing the way we're trying to address the needs of the way the population sees them by allowing them to actually give them money and let them decide the best way to spend it as opposed to deciding for them. Thank you.
Excellent. Thank you so much, Paul, and thank you to all of our panelists. As you heard, they have a wealth of expertise and guidance to share with you today. Now we will proceed with the question and answer session. As mentioned, we received terrific questions in advance from you, our audience, and we have those in today's queue. If you have additional questions, please post them in the text box on the left of your webinar screen. And to begin, Pam, who do you feel should be classified as the most vulnerable population that has the greatest health needs?
Well, you know, this is funny because when I thought about this, if you'd asked me a few years ago, I'd have certainly said mothers, newborns, and children under 5. Definitely a public health perspective, you know, and it's valid because those groups are vulnerable biologically, they're vulnerable socially, childbirth is a risk, being a newborn is risky, so for me, those were vulnerable groups. But as especially now working at Concern Worldwide, I've gotten a much broader perspective. You know, vulnerability is not just at the, you know, sort of level of the individual or physically, but it's also about lack of assets or lack of what we call resilience to shocks. And it really stems from poverty. And one thing that I've learned really from working with Concern is that even in really poor countries, in rural areas where you think that's where poverty is concentrated, some people are a lot poorer than others. You know, and it's people who don't have any productive assets, you know, farm that can bring, crops that can bring them a good level of food security or income. And so those are the people that I now think of as the most vulnerable. I mean, I just listened to a colleague present on a visit he did to Burundi and where they did an assessment. And they found that only a quarter, in the area where Concern works, only a quarter of the households own a plate. So that's pretty basic. And also, countries, you know, that happen to be a lot of the ones that we work in, that have been in conflict or have bad governance are also places where people are really vulnerable, or where there are recurrent floods and droughts or earthquakes and landslides. I mean, some countries are disproportionately subject to those things. So I think the people who live in those areas, and particularly the poorest people, are the most vulnerable. You know, so it's a broader definition that includes economic vulnerability and vulnerability related to conflict and shocks, and just having very little. So that's how I've evolved, actually. It was an interesting question for me.
Wonderful. Thank you so much, Pam. And Paul, what have you found to be the most effective models of healthcare delivery for refugees?
Yeah, in fact, I don't think there is one can say what is most effective because it is so context specific. But I think there are some generalizations, and it's taken us probably too long to realize some of these. One is that if we can avoid setting up or establishing refugee camps, but actually work with the local communities, both the nationals and the refugees, to integrate them into existing systems, which we hope that can improve both the quality of care for the national populations as well as refugees. That should help reduce dependency. But a lot of that depends on governments as well as NGOs and UN agencies agreeing to this. And as we've seen, there's a lot of xenophobia and at times valid security concerns as well by host governments. So this is not always possible, but we have seen more and more refugees being based outside of camps in both rural and urban areas, and the goal is to try to integrate them into existing services, but also look at those services that may be missing. One of them being, one of our colleagues said, mental health, which is often insufficient in the host communities. And so we also are trying to work with organizations to improve services for nationals and refugees, but trying to do so within a national system when possible.
Great. Thank you, Paul. And another question for you, Paul. What are examples of successful community-based organizations that were founded by and for refugees?
Yes, that's a very good question, and in fact, probably too few. We have the one that I can speak of firsthand is a Burundian refugee who was a refugee from Burundi who was in Tanzania. So he was a refugee in Tanzania, and he was a teacher. And his wife, and eventually he was diagnosed with HIV, and his wife died of AIDS. And he started, despite all the huge stigma and discrimination because of HIV and AIDS, but despite of that, he declared his status and actually started an NGO within the refugee camp in Tanzania to teach and to try to change behaviors amongst the youth, or at least, let's say, make behaviors more safe. And at the beginning, there was actually some resistance to that, both, I would say, amongst the UN and amongst some of the NGOs, because it was something that was quite unusual. But he was he still is a wonderful person, and he was able to prevail, and the NGO did very well while he was in Tanzania, and then eventually he did move back to Burundi and continued with that NGO in Burundi. But overall, I would say there are insufficient community-based refugee NGOs that occur, and some of that has to do with the laws in the country itself that don't allow this to occur.
Great. Thank you, Paul. And Leith, how can we empower vulnerable communities in conflict zones to advocate for their own healthcare needs?
Great. Well, I'm going to give you 3 examples of approaches that I think are strongest. But before I do that, I just want to share some numbers just to make sure everyone has these. I think they set the tone for the conversation. And these come from a speech that David Miliband, the President and CEO of the International Rescue Committee, gave yesterday at Georgetown. It's a really important speech, so if you can get your hands on it, he's really calling for wide-scale reform of humanitarian aid. But here are some of the numbers. So 60 million people are currently displaced. That's both internally displaced and refugees. 1 in every 122 people on the planet is fleeing conflict. Half of the world's maternal and child mortality is now occurring in war-torn states. And 43% of all children who are out of school, that's primary and lower secondary, are coming from conflict-affected countries. 60% of refugees are in urban areas. So the service delivery model of the camp is clearly not applicable for those urban refugees. And the average duration of a conflict is 37 years, and the average duration of displacement is 23 years. So those numbers alone show you that what we're talking about is now a mainstream issue affecting health and broader development. This is not a tiny portion of the development challenge. This is now at least half of the challenge. So we all need to reorient ourselves to be able to work effectively with conflict-ridden communities. When it comes to how to empower those communities to advocate for their own healthcare needs, I think the evidence points to 3 areas. We need to fund more women in leadership roles right in the heart of conflict areas. That's leadership in political roles on both sides of the conflict, as well as leadership in NGOs, grassroots leadership at every level, from local to national. We need more women in leadership roles. That will not only hasten the resolution of conflict, but it will prevent future conflict. So the numbers are pretty strong there. And if you want to go to a place like the Institute for Inclusive Security, Swanee Hunt and her efforts, you can get all the numbers for why an investment in women leaders is one of the best ways to both prevent and resolve conflict. And, of course, women are very active health advocates. So when you promote women's leadership, you automatically get an increased focus on health advocacy and health demands, because women have tended historically to be the custodians of health for the family. So naturally that's to the top of their priority list. Number 2, and it's already been mentioned, I think by Paul, cash transfers. So a huge proponent of cash transfers directly into the hands of communities. Why does that matter for health? Because more money in the pocket means people have more resources to pay for health. And we know in a lot of these conflict-ridden communities, you have to pay a user fee. Even if we don't like that, that's the reality. You have to pay a user fee to access health service. So more money in the pocket, particularly more money in the pocket of women, will mean a greater demand for health services and a greater health advocacy. Third, education. It might seem strange that you argue for an education investment to get a health outcome, but I think the evidence shows incredibly strongly that the more educated people are, the more they are likely to seek care and to understand the causes of illness and the necessity of seeking care. And I want to mention the name of an extraordinary demographer and ethnographer, Jack Caldwell, an Australian actually, who died this year, but who really pioneered this understanding of the relationship between education and health outcomes, particularly with women. So we know that the more educated women are, the less likely their children are to die. In fact, we know that over the life of the MDGs, about half of those child deaths that were reduced, and that was 6 million, were the result of increases in education of the mother. So when women become more educated, they become more effective mothers in terms of preventing and taking care of their children's health. So those three, more women in leadership, cash transfers, and educational investments, particularly to women, would be my best buys for increasing health advocacy.
Excellent. Thank you so much, Leith. And Pam, what are your key lessons learned regarding training local community health workers to work with vulnerable populations?
Okay, well, Leith, I love that response. I think that's absolutely right on. One thing that I have learned over time, which actually reveals my own bias, is that community health workers don't have to be literate to be really effective. And, especially in countries where women have lower rates of schooling and lower rates of literacy and also are often community health workers, that is a really important consideration. We've seen this work actually in Sierra Leone, where we have what we call the Essential Newborn Care Corps, women who were previously traditional birth attendants and now are providing counseling and education in their communities, but referring women to the health centers, have done that with very low levels of literacy. And, you have to adapt your training materials and you have to do certain things differently, but in other ways, it works great. The second, and actually I have three, the second is that community health workers, and I implied this already, can be a vital link between local communities and the formal health services, kind of in their midst. It's like a bridge where you can create some trust that might not otherwise have been there. We've seen that in that same Essential Newborn Care Corps program. The community health workers are so well respected that when they began to tell women to use the health services and actually would accompany them sometimes to go there, there was a new level of trust and usage of the formal health services and a mutual support and teaching relationship that developed between the former TBAs and the kind of the frontline health workers in those health centers. So they really began to appreciate each other. It was especially valuable during the Ebola outbreak because these non-literate women were able to really get messages out to their community in ways that the Ministry of Health was having trouble doing. And then the third is, I think cash is really important. And there's been kind of a long tradition of thinking, should CHWs be volunteers with incentives or should they be paid? And, I think there has to be some way in which they are consistently paid. And the model that I've come to really like a lot is enabling community health workers to also become small-scale social entrepreneurs. And they can sell health-related products completely consistent with their role in the community as educators and advisors, and maybe other products that would improve life for people, like baby products or small solar lights that people could use where they don't have electricity. But it enables them to have a livelihood connected to their work. And I want to cite, so that's something that Concern, my organization, is involved with quite a bit. But I also want to cite a colleague organization of ours called Living Goods. They have a model like this where local people have a small enterprise that is health related, and they have had very solid external evaluations that showed a 25% reduction in deaths among under ones and under fives in babies and children in the areas they serve. So it's a model that can really be effective. So those are my three lessons, right? Don't have to be literate to be effective, can really link communities and create trust with the formal health services and need to have a source of income.
Terrific. Thank you so much, Pam. And Lynn, what are best practices for mental health care for refugees and other populations that have been exposed to trauma?
Thank you for asking. That's a great question. And the WHO and the UNHCR, they've developed guidelines, recommendations in addressing stress or mental health problems related to trauma. So group and individual cognitive behavioral therapy that's trauma-informed, eye movement, desensitization reprocessing, or EMDR, and stress management are recommended. And so we have these evidence-based practices that work in Western contexts among Western populations, but as my colleagues on the other panelists have mentioned, and more scholars and researchers are recognizing that while these evidence-based treatments can work in other settings, that they have to be adapted for the specific context. And so that's a part of the best practice is actually doing the adaptation. And there are actually methods that have been developed. For example, the adapted method by Gina Wingood and the DIME approach by Pam Bolton and my colleagues at Johns Hopkins University to adapt evidence-based treatments in non-Western low middle-income settings. And so it's using local terms, the training community health workers, and really figuring out what are the core components of the evidence-based treatments that can't be lost, but then adapting it and making it relevant to the actual context.
Great. Thank you so much, Lynn. And a question now to all of our panelists. How do you apply cultural competency and cultural humility when working with communities? How do you handle being an outsider in such situations? And how do you gain the trust of the local community? And perhaps we can begin with Lynn, if you can share your thoughts on this question first.
Sure. Yeah, I actually am thinking about cultural competency, and this is something that in my teaching and in my work, I've thought a lot about it. And I have some problems with the actual word because I feel like it suggests that one has actually arrived in understanding another culture. And I really appreciate more so cultural humility. Because I feel like it's a better way of approaching it because it focuses more on the process and the fact that one continues to learn and to be open to different perspectives and really emphasizes that you really are an outsider who values the expertise of the individuals with whom you're working with and that they really are the experts in terms of their situation. And so, how I've actually handled being an outsider is really forming solid relationships with local partners and recognizing that I am an outsider. I actually had an interesting situation where I was working with female fish traders and we were doing a focus group. And one of the fish traders, when she sat down and saw me, she walked out and said in the local language that, this was in Zambia, she said in Nyanja, which is the local language, that she had never seen a white person before and she didn't feel comfortable. And I'm actually African American, but I've learned in my work in Zambia that white person is actually synonymous with Westerner or outsider. And so instead of addressing that, I introduced myself to the women and really focused on the fact that I wanted to learn from them, hear from their perspective, and get their voice heard and figure out what their needs were from their perspective. And after I introduced myself and kind of had this what I was hoping was like cultural humility, the women clapped and really welcomed me into the group. And I also think that it's also important to work with all levels, so from the individuals to the communities and also the local and national government. And that I don't do the interviews while I'm there. The assessment is from the individuals that are from the environment of which I'm working, and so that also increases the capacity.
Great, thank you. And Paul, do you have additional thoughts on this question as well?
Sure. I mean, I agree. Cultural humility. I think it's very difficult in acute emergencies because it takes time to build people's trust, and it's incumbent upon us to build that trust. But in emergencies, acute emergencies, it can be quite difficult. And when you bring in foreigners, whether they be UN, international agencies, who come in and often just take over in a domineering fashion, it can be extremely difficult. On the other hand, we have to work with national NGOs and the governments, but we have to work better together, because often the systems are not in place to respond to acute emergencies. In particular, in certain areas such as in mental health and sexual gender-based violence, it takes time to really to gain the trust of the communities, and time isn't always available or sufficiently available to respond, and therefore I think we lose out, frankly, in many ways. I would add that certain areas, respecting the cultures, trying to work with the language, and trying not to impose your own values, which is quite difficult. As it's difficult because sometimes it's you only often know what you where you come from, so it can be quite difficult. And it's again something that is very different when you look at and try to work with communities in a protracted situation versus in the acute emergency.
Wonderful, thank you. And Leith, what are your thoughts on this question as well?
Well, it relates to this fourth lesson, honest dialogue is possible only between equals, and rarely are you in a situation, frankly, where it's perceived as equals. If you're a foreigner, if you're working in another country, if you're from a high-income country, you're working in a low-income country, rarely is it possible to construct dialogue so everyone perceives it to be a conversation of full equals. So the conversation is always distorted, or there's this undercurrent of inequality that I think makes things difficult. So I've come to the conclusion that anyone who finds himself in that situation, ask yourself, should I really be here? Am I really the one that should be having this conversation? Is there a local leader that perhaps we should have been supporting to be having this discussion? Why are we sitting in this seat? And I think if a lot of, international NGOs, UN agencies, foreign governments ask themselves that question, it would really open up a really important internal dialogue for how they're really not supporting local leaders to be having, and local groups to be having these conversations in these different countries. So my question is always to people who are considering a career in development or feeling nervous about this issue, often you do not have to be the one in those situations. There's a better local person to be there giving the arguments you're giving or sharing the viewpoint you're giving, but your organisation hasn't taken the time to invest in those local leaders, and they really should be, because I do think there's a displacement effect between all these external aid workers and local leadership and talent. And a lot of the external forces have crowded out a lot of the domestic talent, and that needs to stop, and indeed the Sustainable Development Goals require that it be stopped. So I'm excited that hopefully we'll have a lot more groups, the external groups, supporting local leaders rather than sending their own people in.
Wonderful. Thank you so much, Leith. And Pam, what are your additional thoughts on this?
Well, I have, I guess, a sort of a personal answer. I mean, the first thing is that wherever I've worked, the first lesson is hire great colleagues who are local. So I've never really been in the situation. I mean, of course, I've interacted with communities, but I always am one step removed, really, in terms of the day-to-day. So that kind of begs the question, because then you're at least working with your professional peers, or for me, the people that I managed and led who are locals or nationals. And I think there, what strikes me is, you develop a relationship, as in my case, fellow health professionals or people who are united by our common purpose in the work that we do together. So I've always found, I enjoy those relationships so much. I enjoy those people and picking their brains, and we kind of build this mutual empathy around the work that we share. And, I don't even think I'm the most attuned person to, kind of subtle cultural or social cues, but I'm a very honest person. I love the work I do. I think my good intentions and motivations somehow come through. And, and then my colleagues sort of, they get to know me, and they put up with whatever areas of cluelessness I'm probably showing at times. So I think it's a lot about the individual relationships that you build. And then again, it's never me that's working with the district health management team or the maternal newborn health promoters in a community. It's always people from that, if not hyper-local area, at least semi-local area within the country. So that would be my answer. It's kind of a personal one, but that's what I feel about it.
Wonderful. Thank you, Pam. And Pam, a different question for you. What is a program that you or your organization implemented but which didn't work as expected? And what were your key lessons learned from the experience?
All right. Well, this might take us a little bit in a different direction, so I hope you'll indulge me. But the one that's a great example is one that I've been involved with called the MAKER movement for maternal and newborn health that has been a collaboration of concern with the University of Nairobi and Kenyatta National Hospital. This program arose out of the crying need for equipment that actually works when you need it. And I think there's nothing worse than being a health provider, trying to deliver a baby and, your exam light doesn't work. You can't see where the bleeding's coming from. So you have the skills, but you don't have the equipment. And we looked at that. And we also figured, wow, Kenya has this big, vibrant community of people who love to tinker and make stuff and design and develop. So couldn't we put those two things together? And that was what this program did. We brought together maternity ward nurses and doctors with sort of engineers and design students at the University of Nairobi. Now, the idea was then we'll locally design equipment that fits the needs, like a suction machine for newborns or a phototherapy light for neonatal jaundice. We'll make them and we'll get a big company to want to manufacture them at scale, after we test them, and it'll be a great, contribution in terms of pieces of equipment. Well, okay, that didn't go quite the way we thought. So things were really slow, for example. We thought we would get much farther with our clinical testing and, actually get to the manufacturing piece, but it took so long to get even things like tax exemption on these, for the university to get tax exemption to purchase things that we ended up, giving up a piece of equipment just to pay the damn taxes, $50,000 US to the Kenyan government. We also learned that most multinational companies aren't interested in manufacturing in Africa. They might even design something in Africa, but they want to manufacture it in China. So that was kind of a sad, at least temporarily sad development for me, although I did realize that maybe local companies will still be interested. At the same time, we realized that the actual existence of this hub where we're bringing together healthcare providers with engineers and designers and getting them to talk to one another and developing those skills, especially on the side of the students and faculty at the university, was an incredible asset to have that new generation of kind of designers and makers come of age and continue to be, to have students continue to be graduating is almost, it's probably more important than any particular pieces of equipment. So, we were very naive going into this, but we accomplished a lot. And maybe as a coda, I would say we actually have been able to develop a partnership with UNICEF and with the Dutch health technology company Philips, which will be able to bring a huge amount of resources and actual people with incredible innovation skills to bear. So, we didn't really get what we thought we started out to get, or what we started out to get, but I think we got something quite valuable.
Terrific. Thank you so much, Pam. And Paul, how does brain drain contribute to health needs? And is there a proposed solution to prevent the departure of skilled medical professionals?
Yeah, another good and difficult question. It's funny when we talk about certain things. It seems like at times we want to do good, but sometimes we do bad. And I would say one of the issues again in an emergency is we come in, but of course we need to and want to work with the local healthcare professionals. But we will often require, whether it be the UN or international NGOs, hiring locals. And often we will pay, even though we're aware of it, and so we try to have a scale that is not too much higher than let's say the local population, and that it's the same across the board. We end up hiring a lot of people that really would be better placed staying in the government. But unfortunately, the government salaries are often so low that it's an incentive, of course, for them to work with some of the international agencies, and we're in a bit of a quandary at times because we need to move quickly and we need to work with the locals. But also on a personal level, it is interesting because many of the people that we have hired and that we often, of course, like everyone, are attracted to who we see to be the most competent. And many of these people end up working with us in different countries. And on a personal level, it's obviously very, very important for them and their family. So it's difficult at times to say, no, it's better for this person to stay in the local government and to perhaps not have the opportunities to develop and also to make as much money as they could and to grow. I think one of the ways to change that, though, and it would require a big shift, is to try to ensure working, whether they be government or local NGOs, to try not to hire them away, but to ensure incentives in some way that is across the board so that everyone could benefit. And therefore, you wouldn't be hiring people away, or if you were, quote, borrowing or seconding someone from an agency, those around them were also somehow benefiting by incentives, financial incentives, so that there would be a possibility for them to return or others to stay. And then finally, I would add that it's not just money, but it's also the possibility of educating and having opportunities to learn that may not always be available in these areas before an emergency occurs and then the international community comes in.
Wonderful. Thank you, Paul. And another question for you, Paul. Refugees oftentimes are not returning to the same doctor or the same clinic. Are there effective ways to keep track of prior medical history? If not, what do you think would be an ideal electronic medical record system?
Yeah, we have been talking about that for a while now, and the issue we have come up with different ideas. One of them, of course, is something called a travel health passport, almost like an immunization card that people could take with them, particularly those with chronic diseases. One of the problems, though, that has come up, and even recently in Europe, is that there are protection issues all the time in there's of course medical confidentiality, but then protection issues. So, for instance, those that may have been receiving, whether it be treatment for HIV, for tuberculosis, or just more run-of-the-mill hypertension or diabetes, when they arrived in Europe most recently, the Syrian refugees and the Afghans, because they wanted to continue on, if it was in Greece, to other areas, they actually did not want to have any sort of identification on them and even go to physicians or healthcare professionals, if possible, because if they did and there was some sort of documentation, they would have to stay in one country, in that particular country. And so it's been a huge challenge to try to, particularly the big issue is interruption and to try to continue with their care. In the future, there may be ways, whether it be giving people themselves some sort of an electronic record, putting something in the cloud, but one has to be very careful again and so has been some resistance because of access by governments and others to these potential records, both in terms of confidentiality, but also in terms of just trying to find people and then refoulement, pushing people back. So it's an issue that is hugely important, but hasn't really. There are a lot of implications that still have not been dealt with sufficiently. But it is something that has been discussed, and even on the various boards talking about moving forward to some sort of travel health passport.
Excellent. Thank you, Paul. And Leith, how should organizations ensure that they support and assist local vulnerable populations on a long-term basis?
Well, I want to take a little bit of issue with the question. I think they should be organizing themselves so they don't have to be taking long-term care of populations. I mean, when you've got average, what were the numbers that I shared? Average conflict, 37 years, average duration of displacement, 23 years. If that's the fact, you do not want humanitarian agencies, the UN and NGOs, still taking care of people after that amount of time. They should be fully integrated into society with jobs, most of which will be in the private sector, and hopefully living a life, same life as their neighbours, their non-refugee and displaced neighbours are living. So I think it's a great question that organisations should be asking themselves. How do we make sure we're not, in fact, creating the dependency that makes these big populations still dependent on us 10, 20, 30 years from now, which is not the case. At the moment, that dependency is built into the system. So I think we want to turn that on its head and have organisations basically drafting their exit strategies after a relatively short space of time. But that will mean much more partnership with the private sector, which is starting to happen, but is not accelerating quickly enough. It means when there's a humanitarian crisis, the companies are right in there from the get-go, not just distributing donated goods, but talking about how do we educate these people so they can go on to take jobs, how do we give them jobs. So the kind of vision that the wonderful Chobani CEO is starting to advocate for full integration of displaced people and refugees very, very quickly, and the private sector really is going to be the main player in that full integration. So we need to see much more public-private collaboration to make sure that we don't create these long-term dependencies that others have mentioned on the call.
Wonderful. Thank you, Leith. And Lynn, how do you incorporate program evaluation in your work with vulnerable populations?
Yeah, it's actually throughout the whole process of whatever intervention we're using. So even at the measurement phase of the assessment, for example, the trauma scale that I've developed and the piloting it in Uganda and South Africa and also in Thailand, we're using what's called cognitive interviews. We're actually asking individuals from the community to describe each item, the meaning of each item in their own words, and then to discuss the relevance for people who have experienced trauma from their. So in this way, we're actually evaluating the relevance of the tool, which could then be revised and then accurately can then assess the trauma symptoms in that context. And also evaluating through rigorous research methods, so using the gold standard of randomized controlled trials. And even if this shows to be effective or if the outcomes are reduced significantly, we also want to obtain qualitative data from the participants, the facilitators, the data collectors, the trainers, on the relevance and the feasibility and acceptability of the intervention. And then finally, getting qualitative information, so in-depth information from the local partners to really understand if this would be sustainable.
Terrific. Thank you, Lynn. And Leith, what do you feel is the most important health solution that is not discussed or highlighted enough?
So I'm going to say no one likes the concept of magic bullets in development, but I'm going to say there is one. I'm going to go out on a limb, and it's modern contraception. So thanks largely to Melinda Gates, we've just started really talking again about this after decades when it was not on the development table. Largely it was a political issue here in the US, but it's back on now, but not enough. So modern contraception is as close as you can get to really flicking the switch on all sorts of extraordinary development gains, whether it's jobs growth, health gains, education gains, because it enables women some exercise of control over the quality of their life, their ability to get educated and stay in school and then to have a job and earn incomes. And after that, everything gets triggered. So modern contraception needs to be right on the table. Now, in terms of conflict settings, I think it's even more important that women who are living in fragile settings have priority access to modern contraception. I'm not aware that we've yet done that. We've talked about a global agenda to increase contraception use and to meet unmet need, but we haven't singled out women in fragile settings enough as almost being the ones who should be first in line, given all that they're dealing with, and all that they're dealing with often with quite a few small children already. They should be first in line to be able to use modern contraception if they want to further control family size. So I'd love to see the humanitarian community really join forces with the broader development community to put contraception and the needs of women in fragile settings right to the top of the list.
Hear, hear.
Great. Thank you, Leith. And Pam, do you have any additional thoughts on other types of health solutions that perhaps similarly don't receive enough attention?
Well, I actually love the contraception answer because I think it's so, it does generate so many benefits, you know, not in just health, but in, as Leith said, in education and employment and earnings. I think it's a great one, and it's cost effective. Contraceptive methods are pretty darn cheap. So that's a good one. Yeah, I want to just stick with that. That's my answer. I'm sticking with it.
Great. Thank you. And this brings us to the conclusion of today's webinar. Thank you so much to all of our panelists and for all of the expertise and knowledge that you have shared with everyone today. Thank you so much.